every AIA we've had, there has been a common theme and suggestion that has been discussed in the US and in Europe, and that is the one regarding disparities and inequities in cancer care.
Talking from a U.S. perspective, just to put a little bit of fact into this, some of you might remember there was an Institute of Medicine report in 2002, almost about 9 years ago now, that got a lot of attention because it really did focus on the disparities in this country. And I'm just going to read you, I pulled out what it said because it's a little scary that it's 9 years later, and in fact recent reports have documented that we haven't made any progress. In fact, we've actually, because of the recession, have gone backwards. But it says that the report found overwhelming evidence that racial and ethnic minorities suffer disparities in healthcare. Factors contributing to differences in healthcare include poverty, lack of access to healthcare, lack of health insurance, language and literacy barriers, and poor expectations of the result of cancer treatment, the doctors, and/or the healthcare system. There are many causes that limit access to care. Racial and ethnic disparities in healthcare contribute significantly to the problem in the United States. Research shows that minorities are in poorer health, experience greater obstacles to receiving care, are more likely to be uninsured, and are at greater risk of receiving care of poor quality than other Americans. And a recent study that was done by AHRQ, by the Health and Human Services Agency for Healthcare Research and Quality, last year said that just what I said a moment ago, that this in fact has gotten worse. A lot of interesting things to learn this. Probably many of you, again, know this from your experience, that this kind of disparity exists, again, from prevention, things like the use of pap smears, which populations utilize pap smears the best, right through end-of-life care, and end-of-life care is very culturally driven, probably more than anything else that we're talking about. And also what I learned, and again, in participating in programs like this and others, is there are really interesting disparities across different racial and ethnic groups. So what might be most common in a Latino population is not necessarily common in an African American or a Native American population. So as you address disparities, and this is a situation where, again, the cultural sensitivity is really paramount, it's not just looking at kind of the continuum of cancer and all the obstacles there, but really the individualizing it to the different groups. I guess I don't want to be negative and jaded with all this, but I do see this as a problem that really has been exacerbated in the past couple of years because of the inequality in this country, the growing inequality in this country, the income gap, and also the large number of people who lost health insurance. And some of these barriers are really systemic barriers that we can advocate, we can do all kinds of things, but they are well-entrenched systemic barriers that are not so easy to address from a societal perspective. I think probably everybody in this room tries to address these barriers, again, within the specifics of their organization and their mission, but that they are difficult systemic barriers. And this, in contrast to what you were talking about at the developing world, this is in what is supposed to be is by fact the richest country in the world, and that this exists.
The goal is certainly that healthcare reform would improve the situation theoretically, but it remains to be seen if it can be implemented, and if so, how it's implemented, as to whether we will truly see improvements. Again, most people can get end of care life by going to the ER, where nobody's turned away. And that's the stupidest way we can provide care in the world. So it is incumbent upon all of us to create opportunities for preventive care and outreach into communities that are underserved. But it is a systemic problem.
It's a huge issue. One of the things that strikes me, though, is going back to the cultural competence thing, to take your point a step further, even within like the Latino culture, there are differences between how Mexicans might think of something and then how a Dominican might think. So there's a whole huge gap. But one of the things that I love about YME's Breast Cancer Support Center is that we do have interpreters available in over 150 languages. So what that can do is now the issue is making sure people know that information. Therein lies the issue. But once someone calls, they can have a comfort level. And I know we have the experience of being able to let people feel comfortable when they call, and that allows them to let down their guard a little bit. But I think that perhaps educating our clinicians, doctors and nurses, public health students as they're learning about cultural sensitivity and cultural competence in schools can somewhat help.
I agree. I mean, obviously disparities is a problem, but I do think that it actually takes us back to the first conversation we had, which is in addressing health disparities, we need to move beyond simply oncology. I mean, I realize this is, we're all here about oncology and helping people with cancer, but if somebody's going to have poor outcomes with oncology, with a cancer diagnosis, they're going to have poor outcomes across the board. And so if we are able to step back and help, if someone comes to us as a result of an oncology diagnosis, but they have other issues, we need to figure out how to help them address all of those other issues. So I think it just provides an open door to be able to be more collaborative across the board.
We've formed something called the Chronic Disease Alliance, and usually as cancer physicians, researchers, lobbyists, we have our elbow in the face of cardiologists, we smack the bottom of diabetologists, we probably spit in the face of that's not very nice, but you know what I mean. We're competing for resources and putting cancer, I've got to stop now. But for the first time ever, with the build-up to this UN thing, we are trying to come together. And when you think about it, it makes complete sense. If we're looking at prevention, there's such overlap between the factors that link us all around obesity, lifestyle, blah, 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 blah. This makes complete and utter sense. Within a socialised healthcare system that we have at home, I come from Glasgow in Scotland. There are some parts of Glasgow in which life expectancy is the same as in downtown Lagos in Nigeria. Median life expectancy is 54 years for men, and it's half of the gap. If we look at in Scotland, I had to write a 20-year plan for the future of the Scottish Health Service a couple of years ago, and the lifespan gap between the wealthiest and the poorest was 17 lost years of life, not 17 months, 17 years. But half of that gap was smoking. Half of it was smoking, and therefore I used that as a lever to legislate against smoking in public places, etc., etc., etc. So there are ways that we can use those sorts of data to make some sensible legislative decisions, and I still think that comes back to being political and having the political will to reduce that gap and sort it out, I guess.
This is a huge issue for our population of patients. There's a high incidence of myeloma in the African American and Asian communities, and so this is something we've struggled with internally in reaching out to these communities. And I'm just wondering from other groups, since I have access to everybody here in this room, I think we have to be really creative about this, and I think that we have to kind of rack our brains and share our ideas on a really kind of broad-reaching way to reach out to these communities. And I'm not sure if maybe starting with some of the different cancer caucuses on the Hill may be one way to go about doing that. But I'm just curious from other groups, that have maybe had some success in reaching out to their patient populations. How'd you do it?
Just in the course of this discussion, it's occurred to me that, and especially with Ivy's comment, maybe reaching out to some legislative groups that cater a message to a particular community, Latino community, African American communities, partnering with those groups that are already involved and entrenched in the community, because I know it makes such a difference when it's like speaking to like. So I think for some of the organizations, maybe reaching out to the existing organizations that are specific to those cultures in your community, if that's regional or national or whatever, that might be a way to go about it, because they'll have that experience, they'll have that communication pathway already with that community. Whereas it's, instead of just looking at it from cancer perspective, but from, here's items that will help with general health and help that population.
And I think we're talking a lot about some kind of broad health issues, risk factors, healthy living, diabetes, and obesity. But there are some diseases where none of that has any effect. I mean, you talk about ovarian cancer, there's not much of a disparity in terms of economics when you talk about survival or racial survival, because there's not that much that you're missing. Whereas you talk about cervical cancer, and if you don't have insurance or you don't take advantage of the programs, you don't get your pap smears, 50% of cervical cancer cases are in people who haven't gotten a pap in 5 years. And so there are places where we can intervene very well, but I think that even if we, got everybody their annual screening and everybody had a healthy lifestyle and didn't smoke, we would still have people with cancer. And so I don't want to say that if we reduced those disparities, then we would fix everything. I think there's a huge disparity still in terms of access to care that we need to work on for people, no matter when they're diagnosed.
We've been doing more and more work in Los Angeles with subpopulations. Recently, we did a focus group with the Armenian patient population and worked with the Armenian Archdiocese. And it was very interesting because we had a contingency of clergy recognizing, and it is not atypical in for instance, the Hispanic community, where things are very much faith-based, and the church and the spiritual centers carry a great deal of weight, and spiritual leaders carry a kind of credibility and trust, especially in cultures where it's very family-oriented. And out of this meeting, what we really learned is that the Armenian church is receptive in asking for tools. The clergy said that the majority of funerals, burials that they do, when they would ask the family, what did your loved one die of? It's cancer. And the feeling of the clergy was there was no way to reach out sooner, because this is a culture that believes in trying many kinds of home remedies, like making a little hole in the leg and taking chickpeas and garlic and grounding it and making a paste, which would really eat away into the skin, and they would be packing their leg till the hole got bigger and bigger with these home remedies from their country. So they said, if you could provide us with educational tools, because we have the outreach, then you would help us, perhaps help our congregants, our community, to access health care sooner with a culture that doesn't really trust the American system. So as I think about this, perhaps we as advocates, maybe one of the areas of outreach could include the religious organizations that have a real strong tie to individuals who may go to their church first for trust rather than elsewhere. I would encourage you, since this is an ongoing initiative now, we're taking this on the road, we're doing more and more AIAs, not only in the US, but in Europe. One of the ideas that we've had was to hold some kind of communications, basically a summit, for the advocates from the US and in Europe to sit down at a round table and begin to hash out these issues and try to form some kind of a cohesive entity that we can partner on a global level. One, I want to thank all of you, and really this panel, because this could not be done without the expertise of individuals who are extremely well-versed. I hope you have a very successful rest of your ASCO meeting. Thank you very much.
Thank you, Selma.